we have the full policy roundtable with us now, and I just want to introduce two additional members. So on far right over here, we have Julia Logan, who's the Chief Quality Officer at the California Department of Health Care Services, a.k.a. Medicaid. And tell us what your role would be in looking at the evidence and making decisions about these kinds of services.
Hello? Oh, okay. Yeah, so we are up to our necks in the opioid epidemic, and I know that we've all talked about this, but it's a huge issue that we around the state and in Medi-Cal have been trying to address in many different policy arenas. So this subject and alternative therapies has really risen to the forefront. It's kind of maybe it's a serendipitous thing that's been happening, is elevating these types of therapies. So where I work, we're involved in analyzing these therapies and trying to figure out how to disseminate them throughout the Medi-Cal system.
Okay, good. So you actually are in a position in which you would be making decisions about, yes, we're going to pay for yoga, and here's how we're going to get it accessed through our system, yes? Mm-hmm. Okay, that's great. And at the other end, far end, we've got Tony Van Goor, who is the Senior Director for Medical Affairs and Medical Director for Policy and Health Technology Assessment at Blue Shield of California. And Tony, why don't you just let folks know where you as an organization are with your thinking, and kind of similarly, at what stage are you in considering how all this fits together?
Certainly, thank you. My primary responsibility is to deal with the PPO side of Blue Shield of California, which actually comprises probably about 3/4 of our membership, and I'm the guy with the target on my back with respect to policy and policy determination. Just right there. But at any rate, echoing what Julia said, we've always been concerned, obviously, about the opioid epidemic and other plans and programs that we can offer our beneficiaries to help combat this. We have actually several already in place that I'll be happy to talk about. But as far as that's concerned, we're looking at alternative medicine actually very closely, and actually we've been doing it for some time. Our policies on acupuncture date back many years, and in terms of how we manage it and how we typically approve it. So as far as that's concerned, we're on board there with CBT, with the mind-body therapies. We do offer those as well, and I'll go into detail on that later. But that's my role.
All right, great, thanks. So I know we all want to get really quickly, in some ways, into the weeds of coverage and how to make these things available. I want to make sure we eat our vegetables first a little bit before we get to that, the juicy part. So one is to make sure, because people do look at our reports for this, can we just focus for a few minutes on what we've learned today about the future research that is needed to make sure that patients and clinicians and payers can make better decisions about these kinds of interventions. And again, we picked a relatively small subset out of a much broader set of mind, body, and other kinds of approaches. So whether it's around, well, there are lots of different ways I could frame this, but let me start with the clinical experts, perhaps, because you guys have looked at this very deeply for years. If you could give the recommendation that would be followed and change for the better our ability to make evidence-based decisions 5-10 years from now, what would that be? Ravi?
I'd say one of the things that we need to do, we've found some preliminary evidence suggesting the efficacy of these interventions. We need to look and see what works best for what patient population, and in what combination and what dosing of these different treatment interventions. As Penny had mentioned earlier, a lot of these things don't necessarily occur as single-line treatments, but they're combinations. So what combinations work best for what types of patients? I think we really need to have that type of information so we can help inform treatment.
So let me push back even a little bit on that, though, because yes, but those trials would be enormous, right? Because the difference in outcomes for low back pain over lengthy time is so small that you would need thousands and thousands of patients, and you could have them randomized to CBT plus MBSR, or maybe that wouldn't make sense, or CBT, acupuncture plus CBT, clustering the different things. Do you think that's feasible? Do you think that's the recommendation that we should be shooting for, or is that not feasible and there are other targets? For instance, I did take your point, though, about the dosing intensity that I believe, yes, you raised also. We don't know whether 5, 10, 15, 20, 25 visits for fill in the blank is is there a dose response curve, right? We don't really know if there's a plateau, a threshold. Anyway, so to me that was really clear that we should advocate for that. The other I'm a little bit less clear on because I'm just not so sure it's possible.
I think it's challenging, but it's certainly possible, and I think it's also needed, because I also think that a lot of these studies that focus solely on back pain or solely on neck pain, we very rarely see those types of patients in our clinic. Oftentimes the people that we see have a constellation of different things going on, and so I would say that in a lot of respects, even the things that we base our findings on, those are very clear, pure patients, and I don't think that necessarily reflects the diversity of what we really see in the clinical settings.
So let me jump on that too. So for the clinical trials in this evidence base, and is there actually a requirement that they not have any other kinds of pain other than low back pain, let's say? I mean, could they if they have neck pain and low back pain, are they basically ineligible for the study?
I think for a lot of the studies, I'll defer to Jeff, because Jeff probably knows more about this than I do, but I know a lot of the literature I've reviewed, they try to keep the sample size as pristine as possible, because there can be so many confounding factors, and so a lot of times that is exclusion criteria if people have other pain conditions beyond just back or beyond neck or whatever the item is being studied.
And you think it would be helpful to try to have a broader set of patients with other comorbidities included?
It makes it just statistically dirty, but I think that it has greater real-world applicability.
Robert, what do you think are the biggest priorities for research?
This is related to what Ravi said, but that is pragmatic clinical trials. So all the trials that we've evaluated today are RCTs, fairly well controlled, making sure adherence is high, and this allows us to make conclusions about the health benefit of each one. Now what needs to occur is have insurance companies, either at a demonstration level or large level, implement them, and then collect data on utilization, opioids, MRIs, epidurals, etc. And what you'll have then, though, is now a much wider mix of chronic pain patients. Some people will adhere, some people will not. Some people will have comorbid neck pain and back pain, and that would be very important data, for us to have. Not to slow us down, but that is the kind of data I think we need to collect.
All right. Where do we stand as far as the patient-centered outcomes? Do you guys feel that they're standardized enough so that the studies are using them in a consistent fashion that allows us to kind of compare them adequately? Are there real gaps where the field needs to either standardize what they've already got or develop some new kind of outcome tool? What do you guys think?
I think there's reasonable outcomes right now that are patient-reported, whether it's RMDQ or the PROMIS measure. So I don't see that as an issue. What I will say, and this is sort of taking off my hat as a quantitative researcher and go to mixed methods, there are also qualitative method studies, some of the same studies done, for example, with ours or in the acupuncture studies, that describe the other benefits that occur, which we're not focusing on, but I think it's really worth mentioning. The degree of empowerment that patients feel when they do an MBSR or a yoga class, feeling like, hey, I'm now taking control of my health. It's not just waiting for the pill. The sense of connection they feel with others and acknowledgement that they're with others with chronic pain decreases some of the isolation. And again, these things, they're not going to get into the quality of life measures. They're not going to get into the patient-reported outcomes, but they are additional benefits that we need to keep in mind, I think, when we're talking about the relative value of implementing these.
Okay. Ravi, anything to add?
Patient-related outcomes are critically important. With American Academy of Pain Medicine did a survey of psychologists, of physicians, and also patient populations through the American Chronic Pain Association, and found that there's great disparity in how frequently patient-reported outcomes are used. But one of the things that I also find, though, one of the things that's important is not just obtaining those patient-related outcomes, but what do you do with that? If you're just collecting the data but you don't truly use it to inform your care, then you've lost the benefit of having those outcomes. And I think that that's a bigger challenge, is not just how we collect it, but what do we do with that information once we have it.
All right. So let's go from, and actually for the panel, if you guys have questions or comments, except for Kim, you guys can raise your 10 cards. I'd be happy to call on you. Go ahead.
I just want to put a plug on the research. As wearing my clinical hat, it's really annoying that pregnant women are excluded because, back pain is a major complaint for pregnancy. So as we put our plug in for things that we need to study, it'd be great to study that as well.
It's a great point, and you know the reasons why they're excluded, because it's a different physiology, but you're absolutely right.
All right, so let's build up from the clinical decision-making to the coverage, too. So as clinical experts, I'm sorry, we'll get everybody involved soon, but I'm clearly zeroing in on these guys to start with. So we've just heard that the evidence, and I think the vote was, I forget, but in the main, it was judged that it's hard to distinguish the net health benefits for these different interventions. Most of them were voted to have adequate evidence that they're better when added to usual care. But to say that yoga is better than MBSR, is better than CBT, is better than acupuncture, that we're not there yet with the evidence. So, from a clinical expert perspective, and you also said that there's no way to know which of these would be better for an individual patient. But a lot of these studies obviously were done by people self-selecting. They saw a sign that says there's a study for, do you have low back pain? There's a study of acupuncture going on, and they find their way into that study. Do we need all of these covered to give choice to the doctors and the patients? Or if they're all kind of in the same soup as far as effectiveness, should we have insurance coverage and clinical decision-making that starts with the cheapest one, the most cost-effective one? Or do you need to start with one of all five?
It's a great question. In clinical practice, when I and others evaluate patients with chronic pain, it's incredibly important to do an assessment of what their preferences are, what their history of treatments, both successful and unsuccessful, are, and what's their current level of patient activation. In other words, how motivated, how willing are they to, I want to try that yoga classes versus that sounds like a bit much, I'd like to have a pill. And so shared decision-making has to occur, and you take that fused with the evidence to come up with a treatment plan. And so given that type of approach, I think you need all these options. There are some patients who will say, I don't want to do acupuncture, I'm afraid of needles. Now, I have an argument for that, but suffice to say, that's how they feel, so that's not going to be a place to go. My aunt did yoga, and she had a really great response, so I want to do yoga. And so I think given the relatively equal benefit in the clinical trial setting, I think we need to have some of these options so that we can kind of match a patient with their therapy, not based upon the evidence in a paper so much, but basically on their values, preferences, availability, etc.
So Penny, as I was asking that question, you had a pained look on your face, and then as Dr. Saper started to talk, you relaxed, you were happy. So, from a patient perspective, what was I triggering from the patient perspective?
To start with the one that cost the lowest amount, that bothered me a lot because that may not be the best treatment for that individual, and they may have tried it 10 years ago. They may have tried it 5 years ago, and I agree with everything that he said. It depends on the individual. It depends on their motivation. But I want you to keep in mind that the goal of pain management is not to get rid of the pain. And we keep hearing about measuring the pain, but it's to improve quality of life, increase function, reduce their sense of suffering. There may always be some level of pain. And so I think we don't want to focus on that. But I also think that, the attitude that the person comes into a treatment with, I also think that just giving them the validation with, like the CBT, that there's other people people there that I'm not alone, because pain is very isolating. But I think that, any of these treatments, and I heard, I forget which one it was, that I heard, that if you just offer it, there are so many providers out there, and they'll just throw up their hands and go, I don't know what else to do for you. So if they have something, at least, we don't know how it's going to work, but the person with pain has to allow these to work as well. So, there's a lot of...
It's a partnership.
It is a partnership, and the person has to always be at the center of the treatment, and I've said that before, but it's patient-centered care, but they have to be an active participant and can't be a passive patient. So if they don't buy into it, it's not going to work, if they're afraid of whatever. So I think that don't just choose the cheapest one. That's a terrible statement. It bothers me.
Well, every once in a while, the cheapest one is the highest value, but not necessarily,
Maybe.
Obviously. So we'll see. Christine.
Maybe, but that shouldn't be the basis.
So in my organization, we have different people sometimes responding to new modalities being covered in different ways. And one of the ways of the people who are in charge of the purse strings is, oh my God, now I got to pay for this. I think what we've seen today in the discussions, and maybe I'm wishing we'd thought more about this earlier on in this analysis of what is the alternative cost. So what truly is the cost of the usual care in terms of surgery, and then what is the harm of usual care in terms of complications of surgery, in terms of drug abuse and alcoholism that derive from trying to manage the pain when there is no other way, and even suicide from despair. And I think that if we really, even as a society, get a real handle on what that cost looks like, then people will say, hey, this is actually a much better way to go. To authorize these treatments if they're counterbalancing the harms of usual care.
That captured what you wanted to say, I'm guessing.
I just wanted to add to that. I always have something to say. When you look at the amount of people that are dying from different medications, and I know a lot of us that have been in the pain community for a while, we pretty much know that our life expectancy is probably, if you take medicine, about 5 years less than the normal human being, because we take medication. So I think that, and that's not for everybody, but I'm just saying that happens. If you look at the amount of money we're spending on treatment for drug and alcohol abuse, people dying, and I'm pro opiates because I didn't have a life before opiates, so I was still in my bed. So, but it may take a combination of all of these things. But I would be pro. If any of these work better than a pain pill or whatever, try it, Try it. It has to be better than what we have. People are dying every day, either from failed back surgeries, they lose their will to live, if they go to jail. I know people that have chronic pain that sometimes they hang themselves if they get sent to prison. So we have to look at the other side of all of this, and look at the cost effectiveness. And I have to add this as an African American growing up in an impoverished neighborhood. The people in my community did not get treated properly for pain. So all of them were just going to be addicts and alcoholics. They could not get proper treatment for their pain. And that's what they went to get some relief.
All right.
Thank you.
Dr. Rashad, let me circle back to you because I do want to jump into the insurance issues and come back and see if we don't address your question, your comment. So, Tony and Julia, you ready? To build the world's greatest coverage policy for these interventions. And I'll let you start with any kind of comment, but what I'd like to actually try to do is to say, if we were going to provide some kind of general recommendations for how to think through, how would you write the language around the type of providers, the qualifications of the patient? Should they have to have failed something else before they get a chance to try one of these? Can they do more than one at the same time? And how, we're going to walk through acupuncture, each one. What's the duration of the treatment? Because for an insurer, you can't just say, I cover yoga, or we'd all be there tomorrow probably doing it for the rest of our lives because it's great. So let's talk through how you actually have to think about fashioning an actual coverage kind of policy, and then we can talk about payment and kind of network issues as well as part of that. Tony?
Okay. All right. Very good. Thank you.
Give you a big job
but
there.
We'll try to knock it down as best as we can. First of all, there's a lot of practical considerations we have to make with respect to certainly medical policy and coverage policy as well. I will say at the outset that for my PPO plans, there is no medical policy specific to acupuncture. So in other words, if you request acupuncture from a medical policy point of view, it's provided, and we don't place limitations on it at this particular point in time. Now, you can argue about the propriety of doing that, and actually there's arguments going on as far as we're concerned right now concerning whether or not we can continue to do that, because there was an explosion once we started doing this in requests for specifically acupuncture, and we can talk about the other therapies, but acupuncture in particular, to the point that I was curious, and so I went back and talked to our medical utilization people about it. Of our PPO membership, right now our count in 2016 was 13% of our total beneficiary population utilized acupuncture services to some extent. That seems extremely high to me, and believe me, I told them to go back and look at that data again. But with respect to utilization, because we don't have limitations on it from a policy point of view at this point, the use of acupuncture has exploded for Blue Shield of California, to the point that, practically speaking, we have to look at different considerations with respect to approving it from a policy point of view. Certainly, we're looking at evidence, we're looking at efficacy, and we're looking at safety. Well, safety doesn't seem to be too much of a concern. And certainly what the ACP has done with respect to their guideline earlier this year, certainly what ICER is doing with respect to augmenting that information is very, very helpful to us and will definitely help us. But there's a number of other considerations that we have as a health plan that we really have to consider, and I think one of the first ones is that consistency of levels of expertise of providers throughout the state. Do we have a way of measuring that? Realistically speaking, I don't think we do at this point in time. Certainly we have the Acupuncture Board for the state of California, which demands licensure, but is there consistent standards throughout the state? No, there isn't, and for because of our responsibility to beneficiaries, we have to make sure that they're getting quality care when we're paying for it and when they're receiving it. Certainly network adequacy is an issue for us too. There's some parts in Northern California that do not have good coverage for acupuncture services. We're aware of that, and hopefully we're trying to fix that if we can. Concomitant therapy along with acupuncture, what else are they getting? Is acupuncture, for instance, the only answer to pain management? Do they have to still receive the narcotics? Do they still have to receive the other concomitant forms of therapy? If we put criteria in place, how do we enforce them? And how the hell do we get doctors in primary care to use them? Is another concern that we have. We can set up a wonderful program. We can set up a wonderful program for paying for this, but in a 5-minute visit, how do we get the proper education given to the patients that this is valuable, that we believe this is valuable, that the insurance plan believes this is valuable? How do we get them to teach it, and how do we get our beneficiaries to use it? I think with respect to the other, for instance, quality issues and the like, our huge concern is how to assess quality, how to gauge quality for acupuncture. We can talk about the other services, CBT and the others as well, but those are our concerns as we go forward with this.
Okay, thanks. And I know I do want to circle back to the question of engaging the primary care physicians, whether your vision is some kind of center of excellence where patients are first funneled and then sent out or whether, but let's come back to that, because
Okay,
I want to give Julie a chance to, from where Medicaid sits, and again, I'll come back and get real brass tacks around specific issues around criteria for providers, et cetera, but from the big picture, how are you now approaching the idea of creating benefits in this area?
So I just wanted to give a little bit of background about how Medi-Cal is structured, because it is very different from private insurers. So the Medi-Cal program serves 14.5 million Californians, and virtually all, I would say probably about 90 to 95% of those members are enrolled in about 24 managed care plans throughout the state. And the Medi-Cal program gives the plans quite a bit of autonomy in designing their own benefits. There's certain parameters that they need to follow, of course, and they have contracts and whatnot. But if there are benefits that are not covered by the overall Medi-Cal program, plans may offer those benefits to their members in specific counties. And an example of that is the Acupuncture Benefit. The Medi-Cal program does offer that as a benefit. It's a relatively new benefit that started at the end of 2016, but prior to that, certain plans were offering that benefit, like the Partnership Health Plan, which offers which serves the 14 northern counties in California. They were offering acupuncture and chiropractic care as part of a program called Managing Pain Safely, and that was a very comprehensive pain management program really focused on opioid safety. And it was a comprehensive way to limit opioid overprescribing and decrease pain. And they did, in the first 21 months of their program, they decreased opioid prescribing overall by 50%. And they didn't look at specific pain parameters. Other plans have done that. But there really are standouts in the Medi-Cal program in terms of driving down prescribing and decreasing pain. I'm not sure that answered your question.
It does. No, it did, because it helps set the stage. And we'll circle back again to a bit to the structure of how we link the patients with the doctors with the centers.
Have they published the results of that program?
Yeah, actually, that's all on their website. I can give.
We'd love to be able to reference that in our report.
Yeah, it's an amazing
yeah,
thing
that's
that
fantastic.
they've done. Yeah.
Okay, so I think it will be helpful if we talk about, again, about the specific options you think and best practice, if you can state it, for identifying first the patients, if we're building a coverage criteria, patients who would be eligible. And let's just talk about acupuncture to start with, and we'll kind of go through the others to see if they're very different. Then we'll talk about the criteria for the clinicians to provide it. And we'll talk again about the duration or anything else about the coverage, because the duration and the number is going to be a part of your coverage policy. I'm sure it already is. So let's start with the patients. Covering out acupuncture. Any patient who wants it, any patient who has tried something else and not had success with a certain number of months, any specific, are we limited to back pain and neck pain? How would you right now think that payers have kind of choices, and how would they write their coverage? Okay. Tony, since I know you have, well, yours is wide open right now, at least on the PPO
Right now it is, but it hasn't always been, and we do have some concerns about how to establish those criteria, and we've been all over the place with this. With respect to the quality of medical evidence that is necessary for us to establish coverage criteria, they tend to be probably a bit more strict than has been presented here so far. In terms of looking at evidence to this point, and again, we're in the process of looking what ACP has done, and we're in the process of looking what ICER has done in terms of putting evidence together, and we appreciate that. But at this juncture, in terms of classic medical evidence, in terms of strong evidence of benefit, there's only a few applications of acupuncture that actually have have that level of evidence at this point in time. Many of the applications concerning nausea have that type of strong evidence. There are some types of pain management modality or pain management situations that have that level of evidence, but not many do. And as far as that's concerned, that's important with respect to setting up medical criteria. What can we defend? At this point, we decided to open it up and see what the patient population needed and to see what they've gone for. With respect to our PPO population, we're discovering that about 26% of our claims are for neck pain and 28% are for low back pain for the application of acupuncture. So those are certainly two areas that we want to look at as far as evidence is concerned. With concern to patient selection criteria, again, not much right now, but that's what we're looking at, and that's the evidence we need.
All right. So one way to do it would be to look back at the studies upon which we were all basing our discussion earlier today and say the criteria for their entry would have been some period of low back pain that qualified as chronic.
Yeah, 12 weeks.
And there was no requirement that they had tried some pill or some physical therapy or something else and failed it, but as Jeff said, most of them in the first 3 months would have had some course of treatment. So if you just said the coverage policy is you have to have low back pain for 3 months and have failed kind of conservative treatment, that's one way to write a policy, right?
Yeah. I think one thing that's important that hasn't been brought up yet is the utilization management impact of putting criteria in place. Back pain, low back pain, neck pain is almost endemic. I mean, a lot of folks actually have that. If we put criteria in place, that means we have to judge cases based on criteria. And as far as that's concerned, with as many cases, if you will, of low back pain and neck pain that there are, can we really look at all of those cases and really put strong criteria to them and demand our providers do the same thing? Now, demanding the providers actually document all this stuff.
Right. So how would you make, so let's just jump over that bridge and say, so if you had to say right now, should a coverage determination for coverage of acupuncture require some documentation or attestation of 3 months of low back pain?
Well, reasonably speaking, the evidence appears to say that it should, at least as far as a 12-week criterion is concerned, with respect to chronic back pain, because that's the definition of chronic back pain.
Right.
But again, it all boils down to whether or not the plans have the capability to look at criteria beyond that point,
right.
And that's questionable.
And so at Medicaid, where they do prior auth, but not as much.
For acupuncture.
Not for acupuncture.
Yeah, so our benefit for acupuncture is 2 visits per month. You don't need a prior auth or treatment authorization request. You get a member gets 2 visits per month, and then if more needed, then you need prior auth.
So you get 1 month, just 1 month, 2 visits.
2 visits for 1 month.
And then you need prior auth if you want more. And you told me earlier, do you mind sharing how much you pay for each of those visits?
Yeah, it's a little bit embarrassing. It's $5.79 for a 15-minute visit.
Wow.
So, yeah, I mean, that raises all kinds of further questions, like who in the world would even get paid that much for 15 minutes? You know, a professional wouldn't really want to accept Medi-Cal at that rate. But to put it in context and perspective, 15-minute visit for a provider is about $20. So Medi-Cal rates in general are about 49th out of 50th among Medicaid programs in the United States.
Okay.
So.
How do you guys decide what to pay for acupuncture?
Now, I didn't bring that data with me, but I will tell you it is very likely considerably higher because, again, with the contractual issues that we have in terms of dealing with our providers, yes, that would be.
Right. So obviously I think our policy recommendations can at least address or highlight the tension between having an adequate network and a payment structure that would bring providers into that network and be able to, I guess, kind of support them, if you will. Not sure those student loans are looking too good at $5 per hour for every 15 minutes.
Now that is, just to clarify, that's the fee-for-service rate. So if a provider is paid by the Medi-Cal program in fee-for-service, that's what they get paid. But our plans can negotiate with providers separately, so they may negotiate higher rates.
Okay. So I want to move from the patient to the provider qualifications. It would be part of a coverage policy, but I know that Rita had something she wanted to ask or say.
Thank you. Tony, I'm just curious, do you know what percentage of your patients, your beneficial clients, whatever you call them, in the first 12 weeks get some kind of imaging like MRI?
Along with the acupuncture?
No, just in general, the ones with back pain. But
I can certainly look for that. I don't have it with me right now, but and that's you're hitting on one of the ACP standards with respect to the workup of back pain as to when it's necessary and when imaging is necessary and when it isn't. But as far as that's concerned, I don't have that data offhand.
Because I mean, the data I've seen, but not, of course, from your company, is a lot of people are getting imaging in that first 12 weeks, and to me, that's an even bigger expense and doesn't really make them feel better at all. So I wouldn't want to, you don't want to compare, but you might want to look at the imaging rates and
we're paying very close attention to choosing wisely the ACP program that actually controls that. Yes.
Robert, I'm glad you raised your tent card because I want you to say whatever you wanted to say. Plus, can you, from a clinical expert perspective, is there any reason an insurer, because physical therapy, 5 years ago, physical therapy was the big thing that everybody wanted. There was evidence it should be included in the early, kind of treatment of patients with back pain, in part so that they didn't become chronic. But is there any reason that you think an insurer should consider having patients try physical therapy first before gaining access to coverage for these other options, or is that counterproductive? And you can say whatever else you want to say, too.
Well, what I was going to say was related to that I think it's important when we look at coverage of these is to not require a failed course of X or Y. Having said that, the vast majority of patients I see who are interested in these therapies have had chronic back pain not 3 months, but 3 years or 9 years, and they've tried 12 different things, and now they're going at this. But I think this idea of let's only use these therapies when they failed X, Y, or Z is not useful. We need to think more upstream. Vis-a-vis PT is an excellent non-pharmacologic therapy where we have licensed practitioners and good data on some of their elements. So PT should certainly be considered in this mix. But again, to say PT first and not the other, I think that gets away from the patient-centeredness. And PT, like a lot of these other therapies, there are issues with variation in treatment, and some PTs use non-evidence-based therapies as well. So PT is not a panacea, but absolutely an important treatment.
One of the reasons I raise is just because I know that health plans have been around the block with PT. They have their networks, they have their coverage criteria. So in a sense, it's easy for them to flip the switch and have patients go that route, easier than coming up with a whole new batch of policies sometimes around other things like new networks for yoga, tai chi, whatever else it might be. Ravi.
I was going to add to some of what was just said by Robert, which is there are also unintentional consequences of having sequencing of treatment. So, for example, we'll get a lot of folks who come in for psych treatment after they failed everything else. And so the message that tells a patient is, well, there's something off about you. You're crazy, so therefore we're going to send you to go see the psychologist. And that's very demeaning to the patient. It doesn't validate their experience of pain. And realistically, we want to try to include some of these different things earlier on. There are some studies that have been done looking in the work comp industry at how early intervention can help minimize long-term disability. And so looking at the work of prevention. So I think it would be ideal if clinicians are able to have an armamentarium of things available to them to start with, including pharmacologic and non-pharmacologic interventions, and be able to work with the patient to select what will be best for that person and their specific circumstances. And I think it's important to note that that's pharmacologic and non-pharmacologic. A lot of times we put these in separate buckets and we say we should do this or that, but the reality is integrating these things.
Right. Although it's funny, we've talked about, I've introduced the idea, I should say, of step therapy to kind of challenge our thinking. In some ways, I know people will ultimately think of using acupuncture as the step before you get an opioid, right? I mean, you have to try and fail these before you actually can get an opioid prescription. Anything else that Julia or Tony, would you want to add about your thinking or the other options that you've thought about and discarded when it comes to identifying the patient criteria for coverage for acupuncture? And I'm assuming we're going to think that that's relatively similar for these others, CBT, MBSR.
Yeah, I think, and Julia's brought this up too, I think if there are coverage criteria at all that need to be put into place, they need to be coverage criteria that are easily accessible and easily looked at by the plan.
Right.
What the ICD-10 codes are that may precede the therapy certainly would be an important one. Certainly some of the patient demographics as well too might contribute to this as well. But as far as that's concerned, this is such a huge problem and so widespread that it would overwhelm, I think, a health plan to look much more closely than that. And I agree with respect to looking at step therapy with respect to the fact that patients are different, and patients may very well respond to one mode of therapy and they wouldn't to another, and requiring a step of therapy before might not be appropriate.
So let me boil it down to perhaps the simplest prior auth. Patient has low back pain for more than 12 weeks.
Right. Okay.
Would that be something that would be administratively burdensome to do?
Okay. That may be administratively conceivable. I'd certainly have to talk to the data analytics people as to whether or not we're gathering that type of information now, but that's conceivable.
Okay. Because to me, that's the easiest way to take the most basic piece of the patient eligibility criteria from the studies and bring it over into a coverage policy.
Sure.
But even that, from claims data, it might be hard to know how far back do you go to find the last time they had low back pain coded and then count from then. I know just from trying to do research that that's a tricky thing. Julia, any other thoughts on?
Yeah, well, I'm a clinician also, and so I really value the relationship between patient and clinician, as I'm sure most people do. So I think that relationship and that history that's built up over time is really important in informing what modality should be used for a certain patient. Even if it's not 12 weeks of back pain for this episode, it might have been 2 years of back pain previously. So
Exactly.
Imposing those 12 weeks here and not there gets very difficult to track, and it's also arbitrary and discounts the history of a patient.
All right. So it would be fair to say that any prior auth that talks about a temporal element needs to be administered in a way that recognizes the diversity of patients in some way. But I'm sensitive to the fact that at the level that you're hearing from Tony of patients using acupuncture once it's made available to them, that could be a very large number of patients who tweak their back over the weekend, and there might just be some need to kind of, again, funneling it, because most of those patients, the vast majority, will get better by themselves within 3 months. So we probably, as a health system, we probably don't want to send too many of those patients to acupuncture a week after their first incident of low back pain. Fair? Fair. Okay. Are we ready to talk about, somebody else? Bill.
Yeah, I just have a quick question to Julia regarding the prior authorization. Is there a criteria there where patient satisfaction plays into it in that prior authorization to continue having the acupuncture? We did talk earlier today about having sufficient treatments to get a result. So
Yep.
how does that work?
It's really not the patient satisfaction playing into it. It's the provider requesting it and giving the reasons, the justifiable reasons to continue. Although, speaking of patient satisfaction, the partnership health plan, which we talked about earlier, took into account patient satisfaction when they started their acupuncture and chiropractor program, because they said the two reasons that they started it were, one, because the providers were dissatisfied with just tapering patients off of opioids without anything to go to, without any alternative, and then they thought that it was relatively low risk to do chiropractor and acupuncture, and the patient satisfaction rates went way up.
Right.
So they thought it's a win.
Good. Okay, I know.
you.
Yes, Joy. And then Catherine.
So I'm putting my family physician hat on for this sort of comment/question, which is when I hear Tony and Julia talking about sort of access to these alternative therapies, I think about it from the perspective of seeing patients in my office and trying to get things for them. And I think when you're looking at it, you're thinking about, oh, we have to add these things, it's going to cost us more to pay for these things. We need to restrict them because, we don't want to waste money, we don't want to spend too much money on these things. But the things that are already in the coverage are getting used too much, right, and inappropriately. And even though some things maybe are already covered, like I'm sure you would say that CBT is already covered by Blue Shield, right?
It is.
Right, it is. I agree with you. But if someone comes into me and I have a choice between writing them a prescription, which takes me 30 seconds, and trying to explain to them how to access their CBT benefit, which takes me 5 to 10 minutes, and then takes the patient hours of work, right, to find who's a contracted provider that actually is trained in CBT, who is taking new patients, and then get an appointment with that person, and then pay their, whatever it is, $20 plus copay every time they go see them, versus taking the prescription to the pharmacy one time, costs them a $15 or $20 copay, and, they go get their refill or whatever. It's disproportionate. And, similarly, if I were to try to refer someone on Medi-Cal, sadly my university no longer takes Medi-Cal patients, but if they ever start taking them again, they're starting to a little bit, to acupuncture, how are they going to find that acupuncturist who will accept the Medi-Cal rate? Or even how are managed care plans going to incorporate? I'm really curious how Partnership did it. But meanwhile, I can prescribe Norco, and it's really not that hard, or whatever other pill. And so I would just encourage you to think about, and maybe you have some responses to this, but the disproportionate effort that's required, even when something's covered, to get somebody to acupuncture or a yoga class or CBT relative to what it is to give them a pill.
Okay. All right.
Good point. So let me try to move quickly, just because I want to get to the clinician and then the number of treatments and everything, and hopefully we'll have time towards the end. But Catherine, you've been waiting on.
Okay, I wanted to make a comment about this because I have been a person in a certain HMO for many years, and been with the same chronic pain management doctor, and I ask for a lot of different things, and they don't get referred out, and I just get the answer is, well, nobody will pay for it. The only thing that I get support with is they do acupuncture, like one visit a month. They may do a couple. Also, they will pay partial rate for my chiropractic care. But if I want to do anything else, and I'm on an income by myself and I'm single, I can't do that stuff. I can't afford to do it. I just can't. And I know that probably I would get better long-term results. And I'm also concerned, as we're talking about maintenance over the long haul, because certain things, I think, when you have, like I have pain, it never went away. So I can just get more quality to my life. But it never goes away. I've never had a day without pain in 19 years. So no matter what I've done. So I think that we have to look at the levels of pain when we're looking at the patients, because like she said, some of them, they do better and some of them don't, but they may get some help from doing it. So I guess what I'm trying to say, how do doctors determine who they will go to bat for outside referrals? And I'm not going to use it on my doctor because I'm getting ready to get a new doctor, and I know my doctor would have done whatever he could for me to get me out of pain with alternative things. So I guess that's my question, because I'm hearing some of the people say, well, their pain goes away or whatever, but when you're a chronic pain person, that never, this is my 19th year, that never had a day in 19 years without pain. So what do you do for that patient? Do you go to bat more for them to get these alternative treatments than somebody that just may, over the weekend, just tweak their back lifting a dresser, that they shouldn't have lifted? I can't do any of that. I don't even try it because I would be in the hospital for probably months. So
Now, I know we're talking a lot about how systems of care can incorporate some of these techniques to increase the chances that individual physicians will, again, have greater resources to share for individual patients. The question of, even at that point, what's outside network, that's a very challenging area that I'm not sure.
I know it is, but I just wanted to bring that to the table.
But you're right, it's a real part of every patient's life.
Thank you.
Tony, and then Robert, and then I'm going to try to get us into the clinician kind of criteria, and then we'll talk about how we frame the actual treatment courses.
Okay.
Tony, you wanted to jump in, though, so I wanted to let you know.
I thought I'd just provide a very, very quick answer to that concern. We're aware of that at Blue Shield with respect to the difficulty it is to get, for instance, CBT, MBSR, all that arranged. We work through an intermediary called Magellan. You're probably familiar with Magellan. And what we're trying to do with Magellan is to streamline that process to make CBT and MB and mind-body stress therapy more accessible quickly. It's a process, but we're working it.
I'm going to go so far as to prejudge one of our policy recommendations. I like the way that you framed it. Getting adequate pain intervention through other modalities should be as easy as writing a prescription for a pill. Full stop.
Yep.
And it ain't right now. So something we can hope that the system will work on. All right, let's turn to, are you okay if we forge ahead? Robert?
Quick point.
Go ahead.
I just want to come back to Catherine's point, is that low-income, less educated individuals are disproportionately impacted by by chronic pain.
Yes.
So in other words, the incidence of chronic pain in whites is similar to the incidence of chronic low back pain in blacks, but the impact in terms of disability, depression, loss of income are greater. And then you have a situation where the ability to access these other treatments for those individuals is less than someone with middle to high income. So I think it's just this is just sort of a call to action in the sense that we need to make sure that these therapies are absolutely equally effective to individuals who have less ideal health insurance. And certainly in our clinical and our research studies, there's no difference in interest in these activities between white or black or rich or poor.
Well said, well said. All right, in about 10 minutes, I want to try the impossible. So we're going to try to talk briefly about, again, principles to use to identify the criteria around the providers who will be covered and for the course of treatment. And course of treatment includes both intensity and duration.
Okay.
So let's talk about the providers first. And I guess we can start with acupuncture, but I want you to help us think about distinctive comments we want to make about the other interventions as well. How would you write an insurance coverage policy right now? Is the impetus to make your network whole so much that you just want to say anybody who says they can do acupuncture, will pay them to do it? Because we know that sham works as well as the other kind anyway, so you stick some needles, put it in the wrong place, we don't care. What do you want to do with your criteria for your providers? Tony and then Julia.
Well, certainly with respect to acupuncture, licensure through the State Acupuncture Board is going to be critical.
If there's no state board, is there a state board for acupuncture in every state in the union?
33.
All but about 3. Okay, so we'll take note of that. Okay.
Certainly that.
Thank you.
We would love to work, get a national standard for acupuncture competency. I know that there's testing.
Let's talk about this year. You're writing it right now, so there's no national competency exam yet or anything. So what do you do?
Well,
state licensure, is that where you go? Is that it?
I'm sorry, say again, please.
So I'm just saying, in the current state of what you've got to know about these providers, so I know that there are things that we need in the future, but like if you were writing your coverage policy this month, would you use state licensure? Are there any other criteria you would use for credentialing?
Well, we have to point to an external criterion, and so again, what a reasonable criterion external to us would be a competency exam that is administered at another level. Okay. Do we have that? Well, yeah, technically we do, but as far as that's concerned, again, there would need to be some way of assessing quality of practice and consistency of practice all the way through.
Okay, so we will make a policy recommendation that the state associations or the clinical societies need to develop a clearly defined set of criteria by which quality provider can be defined.
That stays it well. That stays it well.
Okay. Can we run the board now? So we've got that. For CBT, it's pretty well established, right? Who's a provider of CBT? How about MBSR? What do we do?
Yeah.
Any ideas?
With CBT, the practitioners that employ CBT can be essentially all over the board. They can be clinical psychologists, they can be LCSWs, they can certainly be even nurses as far as that's concerned that have some training and some competency. Again, what we would want as far as that's concerned is some standard to compare them against to assure quality of practice. With CBT, not very clear. MBSR is maybe a bit clearer in terms of an established program to look at, to compare them against.
Right. So for MBSR, there is that training program. So what, does the clinician send that documentation into the health insurance company to say, I want to be a covered provider? Is that how you would work it? At this juncture? For Medi-Cal?
It's a little bit different. There's a provider enrollment process.
Okay. Well, certainly. But they provide that credential. Okay. Yoga? Who's a provider of yoga that you would reimburse?
There's what we can do today and what needs to happen. What can be done today is that there is an increasing professionalization now, and there's an organization called International Association of Yoga Therapy where you can qualify as a so-called yoga therapist, with 800 hours of training. So that could be done. Is it ideal at this point? No. And so I think more work over time needs to be done at establishing people who are used to running chronic low back pain programs and things like that. But that's where I would start.
Is it fair, if you were to advise an insurance company today, given you want to try to make evidence-based therapies available, the difficulty in identifying a credentialed, if you will, yoga network, does that make it a little bit less high on your list of things that you think an insurance company should provide? Is it if I'm thinking of myself in an insurance company shoes, that's tough to get started with yoga because I don't know how to define the universe of yoga providers that I feel comfortable with.
It's certainly tough, but it's not undoable, and given the value described, with the numbers, I think it's something worth working on, but it's more difficult than sending in your state licensure as an acupuncturist.
And so this gets to the question of, so if it's difficult to identify, could you imagine an insurer saying, we're going to allow yoga only if the patient goes to a center of excellence for pain management, and we'll trust those docs to know the yoga providers in their community who are high quality. So it's kind of credentialing by proxy. Does that work or not work? No?
I would say no, because just like Joy's comment, how many centers of excellence would there be to refer people to? And so just the capacity is not there, and so it would just cause this backlog, and it wouldn't be very useful. In the Medi-Cal program, plans can really think outside the box in terms of what they can offer. So outside of their capitated rate per member per month, they get like an administrative fee, and a lot of times they use those fees for community health workers and possibly yoga practitioners.
Okay, that's a good point.
And a huge consideration, too, is access. In terms of a center of excellence type concept, wonderful idea, and totally endorse that idea, certainly, with respect to a comprehensive, well-designed pain management program, but we have to make sure that our beneficiaries can actually get to those places. And again, that can be problematic, particularly since a lot of these therapies require repeated visits.
Got it. Okay. Oh, Robbie, I'm sorry, you've had, and Penny, if we have time, go ahead.
So related to some of the CBT, actually, it's a little bit more complicated because most psychologists are able to do CBT. It's part of the training. But pain-related CBT is nuanced. And so there are a lot of folks, for example, who might go look at their insurance list, and there are all these psychologists who are impaneled who have no expertise with pain psychology. And beyond that, how you define a pain psychologist also hasn't been well articulated. So there may be somebody who saw a person that's got arthritis who presented for depression, and so therefore they call themselves a pain psychologist, which is markedly different from somebody who's fellowship trained with pain psychology. But that concept of a center of excellence, there could be some merit to that. There's a plus to that in the sense that, for example, at Stanford, we have a fellowship program where we train psychologists to become pain psychologists. It's a fully accredited program, but they can't see, for example, Blue Shield patients because Blue Shield requires the person to be licensed, and so our trainees aren't able to see any Blue Shield patients. And so if we had a center of excellence, then we would have the umbrella where we would be able to see them because it would be under that umbrella.
So in some ways, you're saying a center of excellence could improve access if it's not the only way to get coverage.
If it's not the only way to get covered. It could be a piece of the solution, but not the solution.
Quick reaction?
Again, certainly, I think one of the salient points to consider with this is that with respect to assurance of quality and the like, certainly academic centers monitor their trainees actually very carefully, and I appreciate and understand that. But as far as that's concerned, again, we're trying to consider as a health plan a consistent level of expertise provided on the spot for these beneficiaries. And so as far as that's concerned, again, certainly something we could entertain with academic centers, and certainly Stanford could present its credentials as far as that's concerned. But I think we'd have difficulty deviating from licensure being a requirement.
Okay. Penny.
I have a number of comments on different things. First of all, the multidisciplinary pain programs, many years ago, and I went through one 38 years ago at the Cleveland Clinic, still has a pain program today. There were, when I started the organization at 37 years, there were probably about 2,000 of them in the country. They were not being paid. They were not being reimbursed. We lost them all. We lost the training for the providers because the interventionalists took over, and that was cheaper, and they did that. All of a sudden, and back in the 1980s, late 70s, opioids were a no-no. They were. I mean, I've seen the pendulum swing till the point where all of a sudden, then they came back, and it was like, where did this happen? She said 50% reduction in Northern California. Mm-hmm. We get calls every day from people who have just been fired by their provider, not even tapered. So when they look at that reduction, what does that mean? That really bothered me because these are people's lives, and their only other choice, we just did a survey of 1,000 people who are taking opioids as part of their treatment. 47% of them said that if they couldn't get their medication, they would probably end their life. So that's I don't know. I live this every day. I've been working with this for a very long time. The other thing is all the trials that you guys are doing, who were the people? Were they out in rural areas? Were they the ones? Who were they? They were 47-year-old females for the most part. That was sort of the mean. So, all of these things that I'm hearing are not really a diverse group of people representing what we hear every day. And that it's been bothering me listening to all of this, not realizing that there are people out there living, and it's not just them, it's their families that are suffering, their children that are suffering. And we really have to realize that if you're going to help these people, let's make as much as we can available to them at a reasonable price so that they can get help. I can't tell you how many don't want to take the opioids, but they don't have any choice because that's exactly what they were given. They were given the 5 minutes in a prescription. So that's just had to say it.
Thanks. All right, so let's move towards what should be, no, I'm going to try to keep going. I'll come back to you.
That's fine.
Because I've heard in bits and pieces that there's a lot of questions around when insurance does cover acupuncture, it covers one visit or two visits for a month, and then it seems like it's spread. It seems like it's a lot less coverage or less visits, etc., less treatments than we find in the studies. Shorter duration, fewer number of treatments. I actually don't know where the evidence would come from to suggest what the right threshold is. suggest, just as a starting point, do we start from what's in the study as the treatment protocol that showed a clinical benefit and say that's what we cover? That doesn't seem to have been what's happened. It seems like a smaller number. And I know the history in mental health is somewhat similar. So I'm just kind of curious, how do we frame policy recommendations for how insurance companies should think about the number and duration of treatments in each of these kind of disciplines? You got your idea? Okay.
All right. First of all, with respect to that, I think one of the big questions that needs to be answered, particularly with respect to acupuncture, I know studies of efficacy have gone out about a year or so, but is acupuncture once entertained, is it something that's going to need to continue forever to treat this? I don't think anybody really knows that. So in terms of framing the duration of therapy, I think that's an extremely difficult question to answer, for one thing. The other thing, too, is yes, you're correct. There is no set number of visits per certain period of time that's known to be scientifically exactly what it should, what we should be recommending. I know some of our plans are looking at as little as 20 a year. Some don't limit it whatsoever with respect to number of visits per year. Some of the plans on the HMO side, but I think again. Those are considerations we have to look for, but we have to have a scientific basis to do it. We have to have something defensible that we can use, and we're not seeing that at this point.
So argue against the idea of taking either the median or the mean or the most influential key study from the acupuncture research community. And it was 12 weeks. It was how many treatments, do you remember?
10.
Throw it out there. Let's say it was 10. Doesn't really matter. So would that be a reasonable place to start for consideration of coverage by an insurance plan? I'll just put that out there as if there's nothing, because that's the basis on which we're judging its clinical effectiveness. It's almost like a dose of a drug. We know that 100 milligrams produced this outcome, and that outcome was what we like, so we should cover 100 milligrams.
Okay. But are we talking about one course of therapy, or are we talking about lifetime therapy? What are we talking about?
Okay, we'll talk about duration.
One course of therapy, 10 sessions over 7 weeks.
It was one course in the study. So there are two questions, but you're good. The key here is that there's what I would call intensity, which is how many over a short period of time, and then there's duration. Okay. Do they get it once? Does it extend for? Can you have it repeated over 6 months, 12 months? So, I mean, I could imagine a coverage policy that does literally just duplicates the protocol, which was a one-time 3-month treatment phase, and then you can't get it again for another year or so. I don't know what you would do, but how would you walk through this kind of thinking? Because otherwise, I'm not sure what else you would do. That's what I'm trying to figure out. What else would you do?
Yeah, well, obviously you want to look at the evidence, but when the evidence is a time-limited trial, it's really challenging, because then you do go down that path of, you only get it for 7 weeks or however long it was. Right. And that's really not the intent of acupuncture. It's more of a long-term thing.
Well, so go to mental health, though. You probably have some limit on the number of visits per year, and maybe they can get that each year. But we set limits across the board in these kinds of interventions. So I'm just trying to figure out what's the principled approach to doing so.
Someone needs to come up with guidelines.
Well, we can put a policy recommendation as far as an approach. So we can have further conversations, but I'm struck by the possibility of suggesting that from a very evidence-based kind of perspective, you try to go back to the strongest evidence you have for the clinical benefit that you're judging worthy of providing coverage for, and that as a principle that the amount of treatment received would be the reasonable amount covered. And you can draw all kinds of other distinctions later about whether that can be repeated after 6 months or 12 months. That is a more difficult, non-evidence-based decision in a way. But at least the early intensive phase of therapy, on a principled basis, could be in a sense founded upon the work from the studies. And we might play with that as an idea to throw in there, because I think it wouldn't be a bad place to start. And then you would talk to your clinical experts and your network people.
And Steve, your point's well taken as far as that's concerned. This is what we have right now. This is where the studies have shown us there may be some benefit to using this as a starting point. But again, with all therapies, it varies on the individual, and as far as that's concerned, again, we'd have to take that into account too. Right. Yes, we probably do need to put, my PPO plan probably needs to put limits on it and probably needs to put criteria on it. We don't right now, but what we're looking for is the kind of evidence that you've presented, so we can at least consider it.
Okay. Kim?
Wouldn't this be a perfect place, though, for the patient-reported outcomes? Like, you give them this intervention, they get better, and then because they got better, they either need to continue it or they didn't get better, so then you stop it. I mean, to me, that seems like a perfect opportunity to actually move our research into our clinical care.
Yeah, but I think the question is, what does that tell us? The patient had a course of therapy, they got better. Should we continue it, or did it work and we stop it?
I would stop it, and if she gets worse, you bring her back.
Okay, well, okay.
Right?
That's what Medicare does for physical therapy.
I think most benefits will be written that way. They'll use it for a certain amount of time, and then if the patient gets better, and if the hard part comes when if the patient, quote unquote, needs it again later, then people will say, well, maybe they need something else instead. Why they need a redose of that thing, because it clearly wore off. And again, they're in the evidence-free zone, I'm afraid. Penny, go ahead, and then I'm going to start to circle.
They don't get better with chronic pain, is what that was the only one to say. They just learn to manage it. There's a difference between getting better and managing.
Improved is a better word than getting better. I hear what you're saying.
Or learning,
right.
Improve quality of life and function.
Okay, so we did it, right? That's it. We created reasonable coverage criteria for all of these things in about 30 minutes. But what I hope we'll be able to do is to pull out, and this, we create a set of draft policy recommendations, and they really don't say insurers should cover it for X amount of time. Just so those of you who haven't worked with ICER before, that's not what we do. We do try to create some kind of perspectives, though, on the way that you could use evidence to start to build coverage criteria and maybe play out some options. So hopefully we can be some help with that. Before we turn to your guys' final comments, I guess I just wanted to put on the table again that if part of the reason we're here today is the concern about the opioid epidemic, we don't have any studies that we talked about today where you have people who are addicted to opioids or on very high doses, and whether there was a goal of trying to reduce their opioid dosing, and we randomized them to usual care or one of these different interventions. So we didn't mention that specifically in terms of the future research agenda, but for clinicians and health systems and patient groups who are trying to wrestle with what to do with people who want to cut back on their opioids or for whom their clinicians want them to, are we still shooting in the dark? Is there anything that we've learned today that could guide us to make any kind of recommendation other than the need for more research?
What we're learning through the Blue Shield Narcotic Safety Initiative is that this is really a rampant problem. I think we're at the very infancy of being able to address that, because we need, first of all, to identify where the problem exists, which practitioners are over-prescribing opioids and are not tapering patients appropriately. To be able to get alternate therapy put in place with respect to that program is a good second step, and I endorse that. But right now, we're still trying to get our arms around how big the epidemic is, who the providers are that are just not tapering patients that are getting huge amounts of meds per day with respect to opioids, and getting that under control and then proceeding on. So we're working on it at Blue Shield with respect to the Narcotic Safety Initiative to at least get that information down so we can progress along the lines you're recommending.
Okay. And I just want to acknowledge that we're kind of working in this zone of talking about new patients almost with chronic low back pain and what to do with them to hopefully keep more of them off of opioids at the very beginning. But we haven't really circled back to the national problem of how do we deal with people who do have chronic pain, who feel like they need opioids. How do we manage the whole question of whether they should be reduced on their opioids if they've been stable for 10 years? Maybe there's not a problem. So there are a lot of individualized issues that we have just barely kind of touched on, if at all, today. I just wanted to recognize that. All right, I'm going to give each of the Policy Roundtable members right now an opportunity to give a one-sentence concluding statement. I've usually allowed one semicolon, but just one. So remember your English grammar. And it's the one thing that you want to make sure, A, that people obviously here in this room, but that we want to try to capture in some theme that we take into the final report, into the messaging, and to the future communications that we have with policymakers. It could be something that you want to ask or hope for from another stakeholder. It could be one thing that you've heard that you just want to make sure that gets put in bold font. So I'd love to ask you for that for one sentence as a way to help crystallize for us the things that you think are most important. And no one ever wants to go first here or last, so I'll go to Tony.
Well, thank you so much. We, at Blue Shield of California, and I think health plans in general, value alternative therapies. We wish to extend them, and we think these are valuable tools with respect to addressing not only the opioid epidemics, but chronic pain in general.
Thank you. Very good. Robert.
I'm going to use that semicolon. Perfect should not be the enemy of good. Semicolon. Having said that, despite some of the uncertainties we're all mentioning in terms of the studies, long-term follow-up, et cetera, we need to implement these therapies, make them available, study the outcomes, and refine accordingly as we learn more things.
Thank you very much. Robbie.
I have poor grammar, so I'm going to use a run-on sentence. I think that we learned a lot today, that there's some evidence to support some of these different therapies. What's important to realize is that these really shouldn't be or, these should be and. We should be looking at how we include these things in treatment that's available right now. There is a need for better research to look and see the true effectiveness over time and for what population, but we also need to make sure that we're able to make it accessible to the clinicians on the front lines.
Thank you very much. Penny.
People living with pain just want their lives back, and they want to have access to all kinds of care, and they want to be treated with dignity and respect. So I think that a big part of this is looking at all those therapies and being able to choose exactly and being offered the modality that's going to meet their needs, not just something that was, this is the lowest cost, or this is what the evidence says we should do this.
Thank you very much. Catherine.
Oh boy, this is hard. I think that if people can receive all these alternative things, I've said it's similar earlier, semicolon, it would decrease the risk of opiate misuse or addiction. However, there is a certain part of the population that will still have to include opioids as part of their treatment, but not all the time. You don't just have to take opiates. You have to do a lot of other disciplines, and that's where I learned it from the American Chronic Pain Association. So now I'm bartering with someone again for acupuncture, because I want to try that now, and I have to see what I can do about yoga.
Sounds good. And Julia?
Okay. A bit disjointed, but no, not you.
I'm fine.
Okay.
I'm not sensitive.
Okay. So these interventions should not be seen as they're in isolation. They should be synergistic, and we should also think holistically and comprehensively about how to address chronic pain in California and in our country, and that includes policy changes, formulary management, physician education about how to treat pain with opioids, without opioids, how to identify opioid use disorder and to be able to refer per treatment, because I think that's really important, and I think a lot of physicians don't even know how to identify that. And then consumer and patient education is also very important.
Great. Thank you very, very much. Now, the way we like to finish is also to allow the CTAF members to have their own one-sentence, hopefully, summary of their key finding of the day. It can be anything. You can pass if you want to, but we'll go around, and I think we've got about 15 minutes left if we want to end right at 3:30, and we've got about 15 of you, so 1 minute or less if we can. Pat, start with you.
Okay, I have a long sentence. So given the nature of the cognitive and mind-body therapies, I'd like to see fewer longitudinal long-term, meaning 5 years or longer, studies with people experiencing different kinds of pain, not just one particular diagnosis, and letting people choose their modalities and study switching among modalities, again, going back to what we know about these, as well as the long-term outcomes, including self-efficacy and mental health and disparities.
Thank you very much. Rita.
As I said earlier, it's great to have therapies that don't have any harms and do have benefits, and I think we came up with some good solutions or good suggestions for ways to make these more accessible to people with chronic pain. And I would like to, of course, see more data, but I'm hoping it can be collected sort of in the real world style and not, waiting for randomized clinical trials for these therapies, because there clearly already benefits. I particularly am interested in more ways that we could steer people away from opioids for chronic pain and towards these therapies.
Great, thank you. Ralph.
My comments really echo Rita's. I think this particular area, appreciating the challenges in doing true randomized blinded trials, really is ripe for the use of real-world evidence with good metrics with which to evaluate pain that can be harnessed and extracted from our medical records to understand best therapies for our patient population.
Great, thank you. And Christine, now I hope this meshes with what you were going to say earlier.
Yes. So as I think about this, I'm struck with our contemplation of an issue that pretty much everybody at least has back pain, hopefully not chronic back pain, but that millions and millions and millions of people are affected by this, either directly or because they're a caregiver or a family member of someone who does. So where are they? We've looked in the past at much less prevalent conditions and had a packed room. Usually the difference is somebody is pushing for a treatment that they have developed and want to sell. And I think that we have things that people try to sell for chronic back pain. They sell surgeries, they sell interventions, they sell opioids. And if we were instead looking at the effectiveness of those modalities, I believe we would have the packed room yet again. And we spent a lot of time today talking about how are we going to pay for something that actually in the scheme of things is very inexpensive. So somewhere the system is topsy-turvy in America. This is my last CTAF panel meeting, and so I feel like I just have to point that out. I think that this body of work is important to try and stem the tide of the corporate interest driving what people are doing to their bodies in this country, and we're all paying for it in many ways. So thank you for everyone's time and attention on this issue.
Thank you very much. Kimberly.
Wow, that's a great segue. I'm going to put my public health hat on and say I'm sort of disappointed at the fact that we haven't talked about prevention at all, and that there are opportunities to teach kids how to lift and prophylactic training for people who sit all day or do repetitive motion. And we haven't talked at all about weight loss and like how 10 pounds can make the difference between chronic back pain. And what are we doing, or what do we know about the chairs we sit in and the beds we sleep in and how that contributes?
Thank you. Rob.
Okay. Past couple of meetings, I've gone after the patient organizations a little hard because I think they're behind the times. I will say to you guys that support and awareness is not where change is coming from nowadays. So in that regard, I would encourage you all to change your focus as patients, trying to get things changed here. On the other hand, this meeting, I'm going to put it on you guys. You need them badly right now, because in this area I can't find a center of gravity to save my soul. There's no focus here, and that's what we're dealing with. It's very hard for us to put our finger on anything here. That's, I think, why we don't have a crowd here. There's just no place where people are focused here. I'm really against the use of patient-centric all the time, but in this case I think it's really needed. We need more patient-centric research, and you guys are the ones to help them get what you need to actually get that done. It's not being done by FDA panels, working on FDA panels and funding from NIH. It's a bigger deal than that.
Thank you. Rita.
First comment about the evidence for the therapies that we looked at today. I think although the number of studies are far too small and the evidence is weak or moderate, we cover and pay for many things that are with far less evidence and that are far more expensive. I think that I suspect that one of the reasons these have not been covered in the past, largely have not been covered in the past, is just due to our own bias about what's medical and what's not medical. And although the evidence is not there, I think, or not there to the degree that we would like, we need to be less biased and cover whatever we can to help something that is so prevalent. As for pragmatic trials, there's no shortage of patients, and the timeline that we have to look at for outcomes is not nearly as long as the timeline that we look at for many, many other things that have great trials. So there's no shortage of patients. We're looking at usually 2-year outcomes, and I think the list of patients to sign up would be really long. From my own primary care hat, someone, I think it was Joy, talked about how it's so easy to prescribe a pill. I cringe when I have to prescribe opiates, not because I don't want to put people out of pain, but because I know the risks of every time I'm doing that and the contract that I'm making with the patient. So I don't enjoy prescribing opiates. And as for uptake for physicians, getting them to prescribe acupuncture, I think it would be so unbelievably easy and fast and rapid if it were easy to do. Prescribing PT takes 30 seconds. It's never denied, almost never denied. Repeat courses of PT are never denied. So I think it would be amazingly easy to get primary care to prescribe many of these therapies if access were there.
Great, thank you very much. Jeff.
Coverage with evidence development, producing real-world evidence may help answer many existing policy-relevant, clinically important, and patient-focused questions.
You get to teach the one-sentence
Thank you.
methods. Thank you. Joy, careful now.
So I have a bit of a follow-up to Jeff, I think, in some ways. One is about research funding, and it strikes me that the research funders are not in the room. So, and that seems common for these ICER meetings, and yet we are frequently calling for different kinds of research, more research about something that's really important and very common. Why isn't it out there? And so somehow this needs to get communicated to research funders, the people who give the money for research, and coverage with the evidence development could help with that, but it's probably not the only thing. And then just two other quick points. One is coverage is not the same as access. That's the short way of saying what I said before, but it's really important. And then finally, I think that it's the comparator is also very important. So when we didn't really talk that much about surgery or even about PT today or about all the anesthesiologists who make spinal injections, their livelihood, and the evidence for those things. But the harms are certainly substantially larger for the procedures. And the costs for PT are substantial, a lot more, I think, than almost any of the things we talked about today. I was amazed when I saw what my physical therapist got paid, or at least what they charged. So those are important comparisons to think about in making coverage decisions, and also in terms of research. What compared to what? So.
Okay, thank you, Joy. Alex.
Thank you, Jeff Tice, for helping me understand the lack of evidence for differences in long-term functional outcomes between these different modalities. One thing that we both observed in looking at this, however, is that there's so many on these tables, so many of these boxes for long-term functional outcomes that say not reported, no data, not reported. And so that we need to keep our eyes on the prize here about what patients value. And what they say to us is that we care about function. We want to be able to go back to work. We want to be able to live without disability independently. And it's really easy and seductive when you're studying pain to only measure pain as the outcome. But we need to keep our eyes on the prize of function.
Great, thanks. Jeff.
I know there's concerns about, opening the floodgate for all these modalities and putting some limitations on it and so on, but I would point out that one MRI will pay for like 25 acupuncture visits. I think we need to change the paradigm from the current, which is, and it's the paradigm in terms of the way providers think and the way patients think. The current paradigm is you get an MRI, a narcotic, a muscle relaxant, and surgery. That's your back pain treatment. And we know that it isn't evidence-based, but I'm telling you, that's largely the reality of what happens in the real world. And I think the paradigm that sort of makes sense is you do education, maybe you do some physical therapy, you do tincture of time because it's quite effective for the acute, and then when you move into the chronic, instead of thinking about MRIs and surgery, you start thinking about modalities, because there's where the evidence is, and there's really good evidence that 5 years from now, people with surgery are no better off. If you could figure out a way to avoid it, that $100,000, okay, I'm being cheap, surgery will pay for a lot of modalities. I just think we need to rethink the way we approach this and kind of think about the terms of, as you do your pragmatic trials, look at the actual total cost of that patient's care, because I think we're just the wrong direction. We've got this mindset. And it really does kind of foul things up. I had a disc herniation years ago and couldn't stand on one foot, and got an MRI because I was curious, and walked it over to the neurosurgeon that was across the hall and said, "Look at this, it's the biggest disc I've ever seen." And he's like, "Well, we can put you on for next Tuesday." And I said, "I don't want you to do surgery, I'm just showing off." And 2 months later, it was, 9 months later, it's better. And that's what happens a lot of the time, but people don't think that. So it's easy to get down that path. So I'd like to kind of reframe just the general overall approach, and I think we can probably get there, but it's going to take a lot of shifting around the way we think about it.
Great, thanks. Robert?
Well, based on the data presented today, I'd really like to see acupuncture, CBT, MBSR, and yoga as covered treatment options for patients with chronic back pain. Devil's always in the details. The administrative mechanisms and the funding will be problematic, but I certainly share your opinion that swapping some MRIs, opioid prescriptions, analgesic pumps, and surgeries could free up some money to do this. And I really would think that personal engagement in the management of this chronic disease condition would be immensely helpful, instead of just vegging out and popping another oxycodone.
Great, thank you. Bill? Yep.
Well, today we've seen the evidence and the lack of it, and we've made a really good case for having these interventions in the provider's toolkit. Not only for the physicians to be able to actually get the kind of outcomes they'd like to see more often, but also patients who live with the dreadful situation of having chronic pain can perhaps see some light and overcome their conditions, having more and greater access to more opportunities to address whatever their pain comes from. So I think we've made that case today. Thank you.
Thanks.
Paul.
Hey, the one sentence here. So I'd say the placebo effect is way undervalued, and any intervention that can provide that at minimal harm, reasonable cost, which I'd say almost all these do, should be made available to any back pain patient who thinks they can benefit.
That's good. I like that. All right. So I'm going to sum up very briefly and then thank you all. So remember when I said this morning why we're here today? So I'm going to give you the other version of that. I think American medicine has just created a complete catastrophe for patients with low back pain and neck pain. We've created a catastrophe for them. We haven't cared for them. We've made them worse. We've just screwed it up. And now we're going to try to fix it. And I'm concerned that we're going to fix it by recreating the situation we had with mental health, which is going to be a diffuse network of people we never really see. We have to go through some middleman to get a mother, may I refer this patient. The access will be horrendous in a variety of kind of ways because the incentives won't be aligned and the structures won't be aligned. And this group had a meeting a year and a half ago on integrating behavioral health into primary care. I think if we can get ahead of the curve and think, what would it look like if we could integrate the kinds of care we're talking about today into the healthcare system instead of, again, going through that painful process of having a fee-for-service, a kind of tightly utilization-managed external approach. How could health systems today, especially the ones that are well set up for this, the Kaisers and the others, how can we learn from them and how can we build the kind of integrated system that would avoid us having to go through that painful lesson that we have gone through with mental health. So if we can do that, then I think using evidence like this will be looked at from a completely different way, even in terms of how we learn about payment, bundles, payment, other ways of kind of caring for patients, and really truly make these each not one-offs, but part of an integrated package of care for patients. So we will work through this meeting, through the materials that will come out, and through kind of our connections with policyholders. We'll hope to have a lot of conversations that will take some of the messages forward that you guys have provided today. So with that, I really would like to thank our policy roundtable members who've come from as far away as Boston and from other parts of the country, the patient representatives without whom we really wouldn't have had the same kind of insights into the experience that you bring to the table. So from all of us, I'd like to first thank the policy roundtable. And then CTAF, again, you guys know how ICER thinks of you. You guys are just spectacular. The way that you wrestled with the evidence and brought your own perspectives into the policy conversation, I think incredibly added to the richness of today's meeting and will add to the weight that the policymakers will take from the recommendations that come out of this. So not to rue the fact that we don't have that many people in the chairs, but the next meeting will be on CAR-T. There will probably be a few people in these chairs. They won't be all as friendly as the gentleman in the back. And since you're the only one there, I would like to thank you for coming and sharing your perspective as well. So we will put this final report out within about 2 weeks. The materials will then be disseminated broadly and, again, taken to policymakers in a variety of ways. But at that, I'd like to thank you again for a full day, and I hope you travel home safely. And CTAF members, will see you back in a few months. Thank you.